Good afternoon, everyone. Thank you so much for being here today. It's my honor to introduce the Jamie Barkin Lecture that was established in honor of his career in gastroenterology and training so many of us across the institution during his near 50-year career with us. And this lecture is really designed to bring in someone that's a true visionary in our field. It's made possible in part by the generosity of Linda Corey in honor of her father, Mr. Kenneth Hoy. And today we're really honored to be able to have a wonderful colleague, mentor, and true leader in our field in Dr. Shaheen coming to join us today. I won't spoil the intro too much, sufficient to say that he is an amazing visionary and a thought leader both clinically, research-wise, educationally, academically, and as a leader in our major GI societies as well. So, Nick, thank you so much for being here. And per custom, I will turn it over to our wonderful Chief Resident, Dr. Rao, for your formal introduction.
Thanks, Dr. Barkin. Nicholas Shaheen is the Bozymski-Heizer Distinguished Professor of Medicine at the University of North Carolina School of Medicine and the Senior Associate Dean for Clinical Research at the UNC School of Medicine. He is the PI of UNC's Clinical and Translational Science Award and Director of NC Tracks, UNC's Clinical Research Center. Dr. Shaheen's research interests include gastroesophageal reflux disease and precancerous and cancerous conditions of the esophagus, including endoscopic treatment of Barrett's esophagus. He has authored greater than 400 publications in these areas. Dr. Shaheen is currently principal investigator on multiple NIH grants investigating aspects of esophageal neoplasia. Please join me in welcoming Dr. Shaheen to today's virtual Grand Round session.
Thank you so much, Dr. Rao, and thank you, Dr. Barkin. What a pleasure and an honor it is to be here today, and I'm so happy to be able to share a little bit this work with you. It's especially important to me, and I feel especially honored because of this. What a pleasure it is to honor Jamie Barkin, who was actually a mentor to me and encouraged me to get involved with the American College of Gastroenterology, of which he had just been the president when I was a trainee. So he made a bigger mark in my career than he probably realizes, and I know that was the case for innumerable others. So what a pleasure it is. And as things go full circle, I will freely admit that I tried to recruit Jody when I was the chief of the division here and couldn't get him out. So I guess that I have connections to two folks in this picture. Here are my disclosures. I have several research grants from folks that make devices or tests in the field of reflux and Barrett's esophagus. I'm going to start with a patient. This is a 73-year-old retired Wilmington police officer. Wilmington, North Carolina is a little town out on the coast. He spends his time kind of going around on his boat. He comes in to see me because food is sticking in his mid-chest with most meals. His symptoms are progressive, now associated with a 23-pound weight loss. He's had GERD symptoms for more than 20 years. He's been medicated daily with a PPI for the last 15. He's overweight, but he's otherwise in good health. With him to the clinic that day comes this barium swallow, which you can see shows a outline of an exophytic lesion in his distal esophagus. So what you're seeing here is the relatively smooth contours of the esophageal wall higher up in the chest. And then you get down in the more distal area, and you see the space occupying lesion that's taking up the area where barium should be occupying. This caused us to move on to an upper endoscopy, which demonstrated this lesion, this exophytic ulcerated lesion in a field of Barrett's esophagus, which you see over there to the right. We took biopsies of that and did staging of him. He was diagnosed with advanced stage esophageal cancer. He received chemotherapy and radiation therapy, but unfortunately had an ongoing poor response with ongoing weight loss. I had him back into clinic and discussed it with him. He talked to me about big pictures and advanced directives. And one thing he mentioned to me, this was in the spring, is that he wanted to make it to his granddaughter's wedding. Because of ongoing poor oral intake, we put in an esophageal stent, and that's what you see in this picture here. It essentially recannulates the area of the lesion. It doesn't really treat the cancer, but it does allow the patient to continue to eat. Unfortunately, this patient died the week before that wedding and never made it to the wedding. This is the epidemiology of esophageal cancer in the United States by year. And what you can see here on this slide, you see a total of 4 lines. 2 of them are for men, 2 of them are for women. The upper 2 lines, the dark blue and the lighter blue line, are cancer rates in men. You can see that, interestingly, squamous cell cancer has decreased in incidence over the years. However, the cancer that I'm going to speak with you about mostly today, adenocarcinoma, has had a meteoric rise, an increase, in fact, the highest increase of any solid tumor in the United States in relative incidence over this time. You can see that the 2 lines, squamous cell cancer and esophageal cancer for adenocarcinoma for women, are the lower 2 lines. Those are quite a bit lower than in men and not moving nearly as dramatically. I showed you that same incidence line, but now I'm showing you a mortality line. And while these 2 lines seem to be splitting over time, suffice it to say this is still a highly lethal cancer. If you get this cancer, there's an 80% chance of mortality within 5 years. If we were making progress with this cancer in terms of screening and surveillance, what you would expect to see over time is that we would diagnose more patients with localized and regional disease and less patients with distant metastases at the time of diagnosis. Unfortunately, that's not the truth. This is an interesting study that looked at the stage of the cancer by year of diagnosis. And what you can see is that the blue portion and the red portion are largely unchanged over time. In fact, the only change that you see that's notable in this graph at all is that we're staging more people as distant disease. This is to say that we're not doing such a good job with our screening and surveillance for this cancer. And we're clearly failing our patients in the battle against esophageal adenocarcinoma. Here's one study. All of these studies look very similar with respect to presentation. It demonstrates that most presentation is late stage, stage T3 and T4 disease. At that point, therapeutic options are few and prognosis is grim. The precursor lesion to esophageal adenocarcinoma is Barrett's esophagus. And that's what you see in these 2 pictures. These are endoscopic photos of the distal third of the esophagus. What you can see here is the salmon-colored tissue that's radiating up toward us is columnar epithelium. And what you should be seeing here is what's in the foreground of both these pictures, which is the pale tissue, which is squamous tissue, such as what's in the palm of your hand. And what you can see here is that over years of acid reflux, the distal esophagus has developed this columnar tissue. The good news about this columnar tissue is that it's more resistant to acid erosion, which is why we think people get it. The bad news is that it can progress to esophageal adenocarcinoma and in fact is the main risk factor for this cancer. If Barrett's esophagus is going to progress to adenocarcinoma, it does so through a series of steps. In the upper left-hand corner of this slide, you see non-dysplastic Barrett's esophagus. I like this picture. What you see in this picture is on the far right, normal squamous epithelium, those pancake-shaped flat cells. On the left, you see glandular tissue, but the glands are very ordered, and you can see that the nuclei are all basally oriented. The glands look very nice and regular. Contrast that with the next step, which is low-grade dysplasia. Now you see the nuclei are larger. They've lost some of their polarity in the cell. That can progress on to high-grade dysplasia. which you can see we're starting to lose now the architecture of the gland. The nuclei are quite large, and that can progress to esophageal adenocarcinoma, which is in the bottom left. I've reported that to you like it was inexorable, that everyone who gets non-dysplastic Barrett's moves on. That's hardly true. In fact, the vast majority of people who get non-dysplastic Barrett's will never progress to adenocarcinoma. The progression rate in any given year for a patient with non-dysplastic Barrett's is somewhere in the neighborhood of 3 to 5 per 1,000. So relatively rare that folks will progress through all of these stages. Now, I've already shown you that this cancer is going up dramatically, 600% increase in the incidence of this cancer since the 1970s. If Barrett's is the main cause, then we should be seeing an increase in trend in Barrett's diagnosis too. And in fact, when you look at the data, we do see this. These are data from a endoscopy unit in Spain, 58,000 endoscopies, asking the question, what proportion of these endoscopies ends up in a Barrett's diagnosis? And you can see both for what's called long segment Barrett's, which is Barrett's of greater than 3 centimeters in length, and especially the patients with short segment Barrett's, we've had a marked increase over time in the number of patients that are diagnosed with Barrett's. Now, some of this might just be detection bias as people became more aware of looking for Barrett's, but I do believe this probably represents a real trend as well. So, of course, the real question is, why is all this happening? Why are we seeing such an increase in Barrett's and an increase in this cancer? And the answer is no one knows for sure, but some postulate that the increasing cancer incidence could be secondary to the epidemic of obesity in the US. And the basic idea here is more obesity equals more GERD equals more Barrett's eventually equals more cancer. And sure enough, when you look at the association of obesity to cancer, you can see that compared to patients who have a low BMI, even those with an average weighted BMI are increased risk of getting cancer. If you're overweight, you're have 8-fold odds, and if you're obese, you're 16.3 odds of getting cancer compared to a patient who's of low weight. And this is adjusted for reflux symptoms. And this is probably still the best paper looking at this. I'm amazed by these maps. As an epidemiologist, I can look at these maps all day long. And if you're a young person looking to do clinical research, I think that these maps largely tell the story of our lifetimes in terms of public health, which is the trend of obesity in the United States. So here's 1985. The cooler the color, the less obese the state is. Here's 1990. We have many more states that have 10 to 14% obesity. Here's 1995. Now we're up to 15 to 19% obesity. Here's 2000, a new color, yellow, for greater than 20% obesity. Here we are now in 2005, 2 new colors added for 25 to 29 and greater than 30% obesity, with, by the way, the southeastern US leading the way in the country. Here's 2010. Now we have a color for greater than 30% obese. And here's the most recent one. It's changed color because we're using cell phones now to do these surveys. But suffice it to say, we've got over 35% now on the map. And all of the states, with the exception of Colorado and DC, are in the hot zone with respect to obesity. 2022, sorry, is the most recent one. Anyway, what do we do now to try to prevent this cancer, and why doesn't it work? Well, what we do now is that endoscopists try to lower the risk of cancer death in patients with chronic reflux by performing screening and surveillance endoscopy. And it's important to get this nomenclature right. The screening exam is the endoscopy of the patient with chronic heartburn. If the screening exam shows Barrett's esophagus, that characteristic endoscopic appearance that I showed you, accompanied by the histology that I reviewed with you, those patients will be brought in periodically to be rescoped, and those are called the surveillance exams. all of our guidelines have now converged to the idea that patients at high risk for cancer should undergo this Barrett's screening. And well, each of these societies, and these societies are the American College of Gastroenterology, the European Society of Gastrointestinal Endoscopy, the American Society of Gastrointestinal Endoscopy, British, and AGA, all have mildly different the criteria for screening. The basic idea is the same. You're taking patients with GERD symptoms and other risk factors. And these other risk factors include age greater than 50 years, white race, male sex. Remember, I showed you the difference between males and females in terms of cancer risk, and we can talk about that later. Obesity, first degree relatives with Barrett's or cancer. If you have 3 or more of those are the patients who we really want to see in our endo unit. And if you're a primary care doc, we realize that you have 1,000 different things to do in your 20-minute visit with these patients. But if a patient is suffering from chronic reflux symptoms or has been on long-term PPI and has these other risk factors, this should be going off in the back of your head. Perhaps this patient should have an upper endoscopy for screening. So how often do these patients undergo these exams? This is a study that we did 3 years ago, asking the question in our healthcare system. Surely, because we have an interest in this disease, our patients must be adequately screened. Not so much. So this was 1,100 patients in our healthcare system that were eligible for screening based on the criteria I just showed you. 61.3% of these patients never had endoscopy. Amongst the 38% who did have endoscopy, we did find quite a bit of Barrett's, 41 or about 10% of those patients that underwent endoscopy did have Barrett's esophagus. And we actually found 3 cancers in those patients as well. But the problem, of course, is that the vast majority of these folks didn't end up getting endoscopy. So amongst the folks who did get endoscopy, perhaps even more disturbing, the real indication for the endoscopy was not necessarily that the patient needed Barrett's screening. It was that the patient was having GERD symptoms that were poorly controlled. So the vast majority of the folks that were getting this were actually getting it because of the problems they were having with reflux. And this was the work of Swati Alluri, one of our fellows. So the biggest issue here, which I'm hoping I'm translating to you now, is that we're not getting to the people that we need. And this is, I think, something very important for those in primary care. Here are 2 studies, different places, different times, but both asking the same question. What proportion of people who get esophageal adenocarcinoma had known Barrett's esophagus before they got the cancer? And the answer invariably when people ask this question is less than 10%. I.e., the vast majority of people that never get this cancer, never had an endoscopy before, don't know they have the precancerous lesion, and therefore they are lost opportunities to prevent this cancer. This is an interesting model that was developed a few years ago, asking the question, what would happen if we did what we wanted to do, i.e., if we did endoscopy on everybody with chronic GERD symptoms? And the answer is that, unfortunately, our current strategies are not really adequate to stop this cancer. And let me show you why. At the time this model was done, there was about 150 people in the United States who were over the age of 40. We know that about 20% of the US population has GERD symptoms. So this would be 30 million of the 150 million with GERD symptoms. So let's focus on those folks for a second, because they're the ones that are going to get the cancer. But before I tell you about that, I also need to tell you that 40% of the cancer happens in patients that don't have GERD. So we've already lost that 40% by focusing on the GERD patients. The good news is that the majority of the cancer does happen in patients who have GERD. The bad news is that a substantial minority of the cancers occur in the 80% of patients without GERD symptoms. Amongst those 20% of patients with GERD, we know that currently 90% of them are not getting any endoscopy. Okay, so only about 3 million of them, or 10% in this example. The data I showed you before suggested that 30-something%, but in general, it's about 10% with GERD get endoscopy. And we know that that 60% of remaining cancers is going to be spread amongst those 30 million patients. So if 90% of those don't get endoscopy, that means we're going to miss another 52% of the cancers. Of the ones that are left, we'll find Barrett's in most of them. And let's say that we're 100% protective in preventing cancer with those with Barrett's, which is not the case, but let's give us more credit than we deserve. You can already see where this is headed. Between the 40% of patients who don't have GERD but get cancer and the 52% of patients who develop cancer who never get their endoscopy, using our current practices, only about 7% of the cancers that are going to happen in the United States are identified in any given year. This is pretty sobering. So we've got to find a better way to detect the at-risk patient. Endoscopy is expensive. It's tethered to an endoscopy unit. It can't be taken anywhere. It depends on patient's insurance status. So we have a lot of problems. And what we're trying to do now is to make endoscopy smarter. And I'll mention a couple things that we're doing here. One that I'll mention to you is that right now, when we do endoscopy, what we do is we take biopsies. We look in those biopsies for dysplasia, that precancerous change I just showed you. What if we had a marker that would tell us years before that this patient with Barrett's was at high risk for going on to cancer? Well, that's what several companies are working on now. This is a test called TissueCypher, which is run on biopsies from Barrett's. And the basic idea is that this is an immunofluorescence marker study with 9 protein-based markers that get stained, and then they do scanning of them, and you get these bright images of various markers of risk for cancer, like P16, P53, Amicar, HER2/neu, etc. And they take these stains, and between these stains and some other morphologic measurements that they get from the tissue, they're able to generate a risk classification for the risk of the patient getting cancer in the next 5 years. And you get a report that looks like this, and it tells you what the 5-year probability of progression is. And you can use that to help plan how you're going to care for this patient, whether or not this patient needs frequent endoscopy. Perhaps they need ablation of their Barrett's, and I'll show you what that looks like in a second. So this can be very helpful in helping plan the patient's care. And there's a growing literature that suggests that this test actually does help stratify risk. There are 8 studies, most of which are case control studies, which have their own shortcomings associated with it. One thing I'll point out to you is that the sensitivity is still not quite as high as we'd like to see it. Sensitivity for progression to cancer is somewhere between 29 and 50%. Although if you do have a higher intermediate reading on this test, your hazard ratio for progression is greater than 5. You have 5-fold risk of progression. But the real issue becomes, is there a better or cheaper way to screen these patients with heartburn for Barrett's? And perhaps if it's cheap enough, could we do it for everyone? And I'll show you a couple things that are being developed. The first one I'll show you is a delightfully low-tech test from the UK called Cytosponge. And all Cytosponge is a sponge that's inside of a capsule. And the patient swallows it. There's a string connected to the sponge. My patients aren't usually that happy when they're swallowing this thing, but you get the basic idea. And this capsule dissolves after 5 minutes in the stomach. Then you pull back on that string, and the sponge collects cells along the esophagus. And the sponge is fairly abrasive, so it actually does lift up a goodly number of cells, about as many as are in a biopsy. And then you stick that in a formalin jug. The cells are dissociated from the sponge, and we spin it down, and we mark it with trefoil factor 3. And that's actually a pretty good marker for Barrett's esophagus. So here's some initial data from the Cytosponge. This is 500 subjects in a general medicine population in the UK, using upper endoscopy with biopsies as a gold standard. For smaller amounts of BE, the sensitivity was 73%, specificity was 94%. For longer segments of BE, this is how much of the esophagus is taken up by the precancerous tissue. And by the way, the length of BE is a risk factor for the development of cancer. Those numbers go up to 90% and 94%. So not too bad for a cheap less invasive test that could be done as a point of care test in a primary care office. And in fact, this is going to be marketed here in the US shortly. And they've done a really nice study of 13,000 patients in primary care settings in the UK. And they showed that they could get a 10-fold increase in the number of diagnoses of Barrett's in the UK by using this technology when compared to standard of care. So that's a pretty impressive study that was done by Rebecca Fitzgerald in the UK. I'll show you a second one this one is commercially available already in the US. This is called EsoCheck. This is a somewhat improved version of what I just showed you because it's a balloon that can be totally involuted inside a capsule. So you can selectively sample only the distal esophagus. And this is what this looks like. This guy has no gag reflex. It's amazing how well he tolerates it, but patients actually do tolerate these pretty well. And you get your sample, you cut it in, and this is actually combined with a somewhat more sophisticated, it's not just immunohistochemistry, it's actually methylation markers. But the results of this are quite good. This is a paper we did with this technology a few years ago. There are two methylation markers, cyclin A1 and methylated vimentin. And the reason you see four AUC curves is that there's one each for each methylation marker and one each for cancer versus high-grade dysplasia and cancer. And what you can see here is pretty impressive areas under the curve that this test does a good job of detecting not just Barrett's, but cancer as well. And here is the sensitivity and specificity of the methylated vimentin and the CCNA that you can see at the top there. I'll box the overall numbers because those are the most important here to say that 91% specificity and 95% sensitivity for all cases. And then they broke it down. The other numbers you see below, which don't vary that much, are for long segment and short segment disease, dysplastic versus non-dysplastic disease. The take-home point is that the test seems to work pretty well. And this is the brainchild of some folks at Case Western that I'm lucky to collaborate with, Sandy Markowitz, Amitabh Chak, and Joe Willis. So now we have a bunch of ongoing non-endoscopic screening trials because I think that this is the way that you help solve the problem I was showing you earlier. How do you get screening to the people who need it? Well, one way that you do it is that you untether it from the endo unit. So we're trying to demonstrate efficacy in large unselected primary care populations. We're also, remember I told you before, 40% of those folks, remember that pie I showed you, 40% of the people that get this cancer are non-GERD population. So perhaps we can extend, if we have a cheap non-endoscopic way of screening, this screening to non-GERD populations. And we're actually doing that study right now. And then the last thing is, can we use, remember I was just showing you those risk stratification biomarkers. Perhaps we can combine these biomarkers of the presence of Barrett's with risk stratification biomarkers to say not only this patient has Barrett's, but this patient has Barrett's and has X% chance of risk of going to cancer in the next 5 years. Then we can use endoscopy very selectively and only go after those who are at highest risk for progression. So this is an exciting time in this area, and I think that this is an area that's poised for multiple breakthroughs in the next 5 or 10 years. Now, I've shown you already the main problem with preventing this cancer, which is we're not finding the patients that are at risk of developing it, and if they are, we're not finding the cancer until the cancer is too large to do anything about. What do we do if we do find precancerous conditions in the Barrett's esophagus? This is an area of progress. Unlike what I just showed you, where I would argue we haven't made much progress in the last 25 years, we are much better at taking care of patients who have precancer and Barrett's. And this is how we do it. So what you're seeing here now is some pictures of some nodularity in Barrett's. In the upper left-hand picture, you can kind of see this darker, more salmon-colored area. It looks a little bit lumpy, bumpy. You're seeing now that the endoscope has got an attachment on the end of it in picture B. And what we're doing here is we're placing a rubber band around that area of nodularity, and we're resecting it such that The area you saw in A is also the area in D, but the area in D has now gone through a resection so that that tissue has been completely removed. And in doing so, we can get rid of early cancer, and this is called an endoscopic mucosal resection. Now, in 2025, after we do one of these resections, we ablate the precancerous tissue, the Barrett's esophagus, and that we have multiple choices to do this. And this all depends on the seminal observation that if we destroy the Barrett's esophagus and you give the patient rigorous acid suppression with proton pump inhibitors, what grows back is not the Barrett's again, it's actually squamous epithelium. So what we think is happening in the esophagus is that there's a pluripotent stem cell sitting in the crypts of the esophagus, and it's sniffing the lumen. It's saying, do I want to grow to be a columnar cell, which is very resistant to acid, but is a Barrett cell? Or do I want to grow as a squamous cell? And if it detects an anacidic milieu, it will come back as a squamous cell. So we need now to ablate this tissue in order to make sure that these patients don't have recurrent Barrett's esophagus. In the old days, we used photodynamic therapy for this, which was a laser therapy. We don't do that anymore. It was hard on the patients and it didn't work very well. We can use argon plasma coagulation, which is blowing argon gas onto the Barrett's, and argon gas is a noble gas, but one of the things that argon gas will do is carry an electric charge, and we can actually put electricity across that gas and burn the Barrett's. This is the workhorse now that in most endoscopy units, and the device that's in your unit right now is radio frequency ablation. I'll show you how that works in a second. We can freeze the tissue. This is liquid nitrogen cryotherapy, where we blow liquid nitrogen onto an area and we freeze the tissue. And then the last thing that we can do is, this is a nitrous oxide balloon-based cryotherapy. And I'll show you a little bit about what these are, but suffice it to say that these are all variations on the same theme, that if you kill the Barrett's tissue, and what comes back is squamous mucosa, as long as there's rigorous acid suppression, and you cut the patient's risk of ever getting cancer by greater than 95%. No one knows which of those treatments I showed you is the best. We don't have very many head-to-head comparisons, but as I mentioned, the most extensively studied and the only modality with level 1 evidence is radiofrequency ablation, and that's what's in most units now. So I'll show you a little bit about that. This is how radiofrequency ablation works. So what you see here is an esophagus, a stomach. This is the device. The device is a bunch of small alternating positive and negative electrodes that are on a balloon. The balloon goes in deflated. It's inflated in the area of the Barrett's. The energy is passed through the positive and negative electrodes, and the tissue is desiccated. Then you go in with a cap on your endoscope and you scrape off the desiccated tissue such that the submucosa is exposed. And then what you'll see is that the balloon is inserted again, and the second round of those ablations occur. We put in the balloon over a wire in under endoscope guidance. And then you'll see another set of ablations of the Barrett's. Now, what I just showed you in 30 seconds, in the real world takes somewhere around 30 or 45 minutes. It's not a very long procedure. And that's how it works. And here are the data that demonstrates that it works. This is the AIM dysplasia trial. This was a randomized controlled trial of 127 patients who had Barrett's with either low-grade or high-grade dysplasia, so precancerous Barrett's. And the basic question was, could we use that intervention I just showed you to prevent these patients from going on to cancer? So we randomized them in a 2-to-1 fashion to either get the intervention I showed you or a sham intervention, and we followed them for 12 months. And the patients didn't know what they had. We had a script in the room so that every patient, even though they were put asleep, heard the same words in the room. They got biopsies every 6 months if they had low-grade dysplasia, every 3 months if they had high-grade dysplasia. And the questions we wanted to know was, number one, could we get rid of the dysplasia? Number two, could we get rid of the Barrett's, get complete eradication of all the intestinal metaplasia? And number three, and most importantly, could we prevent cancer? And what you can see here is that in the vast majority of patients, we could get rid of all their dysplasia. And in fact, in 77% of the treated group, we were able to get rid of all their Barrett's esophagus, all their intestinal metaplasia. If you look at the chart on the right, the sham group, 19% of those had cancer at 1 year. The RFA group, 2% had cancer. So not perfect, but pretty darn good in preventing cancer. The side effects that were associated with this treatment were the primary one was strictures or narrowing of the esophagus, which occurred in 6% of subjects. After that was shown to be efficacious, industry started developing all sorts of different ways that you could get rid of Barrett's. And this is one that I'll show you that I alluded to earlier, which is spray liquid nitrogen cryotherapy. And the first time we did this, I was absolutely gobsmacked that a patient's esophagus could tolerate this. We're freezing this esophagus literally more frozen than an ice cube. And what you're seeing here is a segment of Barrett's that's being treated with this spray liquid nitrogen. And what we're going to do here is we're going to spray it for 20 seconds. We're going to pause the spray. We're going to allow it to reperfuse because actually the reperfusion is the important part here. It generates free oxide radicals that actually destroy the cell. And then we're going to freeze it for a second time. And you're going to see this kind of characteristic cherry red appearance in that area that we just sprayed here in a second as that frost comes off. And then we'll start a second spray here in a second. So that's the way that works. So how well does that work? Well, it actually works quite well. So here are the data. What you see here are the various lines that you're seeing here are Barrett's with low-grade dysplasia, Barrett's with high-grade dysplasia, and Barrett's with intramucosal cancer. And what you can see is that with repeated treatments, we can bring the majority of these patients into complete eradication of their Barrett's so that they no longer have any Barrett's esophagus at all. And if you do that, then what you can see is that regardless of whether they've had any previous treatment with RFA or not, after they're eradicated, they tend to stay eradicated. The likelihood that they redevelop Barrett's esophagus, while not zero, is fairly low. And then the last one that I'll mention to you is the newest kit on the block, which is this balloon-based cryotherapy with nitrous oxide. And this is what the device looks like. This is the balloon that we put down in the esophagus, which is blowing the nitrous oxide. This has the advantage of not just releasing gas into the patient. The gas all stays within the balloon. And this is what this looks like. This is a nice movie that Mimi Canto from Johns Hopkins lent me. What you're going to see here is the balloon. This is Barrett's esophagus, the more salmon-colored tissue there. The balloon's being put up in the area of Barrett's. Now we're looking right through the balloon, and if you look very closely at the central stylet, you can see it's got a hole in it. And you can see there's going to be a little puff of gas come out of that hole to help you target where you want your frozen patch. And this thing rotates in case I was in a place I didn't like it. But now I lay on the pedal, and here comes a big ice patch. And again, all this gas is staying inside the balloon, so the energy is being transmitted through the balloon, but the gas is not, the patient's not having to evacuate the gas. So, and now we're going to drop the balloon, and you'll see a nice patch of frozen tissue where the Barrett's was. And this is what the data, this is a study that we did, a multi-center study looking at this. This is what these data look like. Mimi Canto was the first author on this paper. Here's a patient who had a long segment of Barrett's, had 5 centimeters of Barrett's in this trial. And these were the results. 120 patients who we were able to get a complete response for dysplasia, and 3/4 of them get a complete response for all of their Barrett's and all intestinal metaplasia, 72%. And per protocol, these numbers jumped up quite a bit higher. One patient of these 120 had neoplastic progression to cancer. The safety data looked pretty good. 3 serious adverse events. Most patients had very mild pain associated with it, 2 out of 10 on an average. Only 8% of patients needed narcotics. This is all these procedures, by the way, that I'm showing you. These are outpatient procedures. So we're taking patients who would have had esophagectomy and been in the hospital for 14 days and had almost a 50% chance of a major complication. And we're turning these into outpatient procedures that can be with high rates of success. And to give you an idea of what some of these look like, this is the second treatment. This is after the third treatment. Now they're getting back to essentially normal. That's the hiatal hernia in the distance. If you get one of these treatments are highly efficacious in keeping patients from progressing to cancer. And here's a study called the US RFA Registry, which involved almost 5,200 patients that took patients with non-dysplastic Barrett's, indefinite for dysplasia, low-grade dysplasia, high-grade dysplasia, or cancer itself, intramucosal or invasive cancer, and asked the question, after you get treated, regardless of whether the treatment results in complete eradication of the Barrett's, what's the likelihood of getting cancer? And what you can see here is that the total number of incident cancers in these patients that were followed for years after the treatment was 100 in the 4,859 79, including these patients with high-grade dysplasia, almost 1,000 of them who would have somewhere between a 5 and 20% chance a year of getting cancer. So, and the number of deaths amongst the patients who had non-malignant disease treated was 3 out of 4,900. So that's where we are, and that's not good enough. It's not good enough for a number of reasons. It's not good enough because we're not getting to the patients early enough. So I just showed you a whole array of really amazing things that we can do for these patients, right? If we know that they have Barrett's that have premalignant changes in it, there's a very good chance that we're going to be able to cure those patients. The problem is we're missing those patients. We're not getting to them at that curable state too often. Okay. So that's where we are. Allow me for a minute or two now to give you an idea of where I think we're headed. Okay. And where I think we're headed, if we're going to get to a point where we're doing good cancer prevention, is the following. We're going to screen probably the general population eventually, okay, with a low cost, easy to do point of care test. Okay. And the one that I've pictured here is the Cytosponge, which is the one that I described to you, but it could be any of the ones that are available or something that's still being developed. If you're tested with this, and we'll do this one time when you're 50, similar to what we do now for colonoscopy. And let's say that one-time test is negative. You're done. You have a get out of jail free card. You're not going to be screened for this test again for this disease again in your lifetime, because it turns out if you don't have Barrett's by the age of 50, the likelihood that you will ever get Barrett's is extremely small. Okay. On the other hand, let's say you're positive for Barrett's. Now, right now, that would cause an immediate upper endoscopy to see what's going on and what the degree of dysplasia was in that Barrett's, whether or not there's precancerous change. In the future, I think you're going to get a second panel on this non-invasive sample. And what that second panel is going to be is a biomarker panel for progression of risk, okay, for risk of progression. So the basic idea here is if you are yes for Barrett's, but no for high risk to progression, you're just going to get another sponge again in 3 years or 5 years or some other time. You're never going to have to meet me. You're never going to have to come for endoscopy until not only does your panel say, yes, you have Barrett's, but yes, you have high risk Barrett's. And then the very first time I meet you, we'll give you one of these treatments. Okay. So understand what's happened here. We've collapsed all these endoscopies, all these episodes of care into one single test that we're going to use for decision making for this. And in that way, you take a very costly, very difficult to administer screening program, and you make it into something that makes sense for people that could work in primary care. So we're not there yet. This is where I think we're headed. And this, I think, will be how we fix that number, that 10 to 30% number who are currently getting the screening If we can get into a paradigm like this, then I think we can drive those screening rates up more to where we see colorectal cancer screening or maybe even breast cancer screening. So I want to end with some conclusions, and then I'm happy to take any questions and have discussion. The epidemiology of both Barrett's esophagus and esophageal adenocarcinoma is unfavorable, as I've shown you. Almost all the disease is late-stage disease, and the mortality associated with it is high. Our current screening and surveillance practices, taking patients with heartburn, scoping them, keeping the patients with Barrett's that do from that heartburn population in surveillance, is limited by poor risk stratification and just has not had the uptake that it needs to be effective in the US population. Therefore, even though I showed you all that cool stuff that we have developed and implemented for patients who we know to have precancerous conditions, self-congratulation for improved care in the patients with known Barrett's is largely unwarranted. Remember those yellow pies that I just showed you? I showed you what we could do for the white wedge. We should not be celebrating that we can fix the white wedge. We should be asking why we're not getting to the yellow pie. And doing what we've been doing, but harder, is unlikely to result in success. So people say, oh, if we just had more of a commitment to screening and really beat on the primary care docs to try to get them to send more patients, we would do better. Now, there may be some truth to that, but the bottom line is that the system is broken, not the motivations. Having said that, relatively small changes in our current paradigm would result in incremental improvements. So if you're a primary care doc, think about who you saw this morning. Think about how many of those folks are on a proton pump inhibitor. Were there patients that you should have thought about screening? If so, please do. If you're a gastroenterologist, did you take enough biopsies when you went in to see the Barrett's patient? Was there adequate sampling? Are you managing the patients the way that you're supposed to based on our current guidelines? However, I think embracive disruptive technology and perhaps new non-endoscopic care pathways will be needed to improve our approach to preventing esophageal adenocarcinoma. And I've shown you a few of the disruptive technologies that I think will come into play in the next 5 or 10 years. This is an exciting time to work in this area. If you're a young person, if you're a young gastroenterologist, you're looking for a good place to put your efforts, knowing what to do for folks with heartburn is a worthy outing. Many hands went through into the work that I just showed you, and I want to highlight a few. Here's our team at UNC. That's Mimi Canto, who did the balloon cryo study that I showed you. This is Amitabh Chak, who invented that non-endoscopic sampling balloon I just showed you. This is Julian Abrams from Columbia, Ken Wang from Mayo Clinic, Sachin Wani from Colorado. These are the people whose work that I just showed you, Herb Wolfson from Mayo. This is the basketball arena at the University of North Carolina. I show you this picture for a couple of reasons. Number one is that most years we're usually good at basketball, not so much this year. And number two, the Dean Smith Center seats 18,000 fans. This is the number of people who will die of esophageal cancer in the United States in this year coming up. A lot of these deaths can be avoided, and I look forward to a time when we're more effective and more interventional in our use of some of these technologies. Thanks for your attention. Happy to
thank you, Nick. That was wonderful. Very didactic, illustrative, and exciting. What's happening? I'm wondering if there's any insight. And there's a couple of questions in the chat which I hope we'll get to. But given the importance of obesity or the influence of obesity in causing or associated with reflux and Barrett's esophagus, is there any information that after a significant amount of weight loss, that if the GERD has been improved, that the risk for cancer is been markedly reduced, and therefore you don't have to necessarily screen them? Or once the insult had, you're at risk forever? Is there any information on that?
That's a great question, Roy. And the answer, unfortunately, appears to be more the latter than the former. What we know about weight loss in the setting of Barrett's is that weight loss neither induces reliable regression of the Barrett's, nor does it seem to much change the cancer risk. So your illusion is spot on, which is that the factors that cause Barrett's to progress may be different than those that cause Barrett's to be existent in the first place.
Dr. Gershengorn, you have a question in the chat, and then we'll go to Dr. Punjabi. Do you want to unmute yourself if you can? I know you're in the ICU. Well, why don't we go on to Dr. Punjabi until Haley can get back online.
Great seeing you. Thanks for doing this. Long time no see.
Good to see you, Naresh.
Question about, though this was not the topic of discussion, question about reflux and bile reflux. Use of PPI is something that you and I discussed in the past. We can avoid Barrett's if we avoid the GERD. What are the downsides of chronic PPI use? I know you've got some thoughts on that, because from a prevention standpoint, that's the way to do it if we can intervene and not even get to the stage of where you are, which is screening, et cetera.
I'm so glad that you asked that, Naresh, and seeing a old classmate and good friend is lovely on this. What I'd say about it is this, and I think that this is an important message for us in primary care, that in patients who need PPIs, despite the litany of things that can be found on the internet about all the evils of PPIs, these are in fact, when taken at the standard doses for folks who have an indication, very safe drugs. That in general, these are very well tolerated. For most of the putative side effects, the strength of the association of any side effect is inversely proportional to the quality of the study. And in fact, there is a randomized controlled trial of 17,000 patients who are randomized 1-to-1 to PPI versus non-PPI before being given anticoagulants to see if bleeding could be decreased. And analysis of that study demonstrates that many of these things, the neurologic complications, the bone health issues, the kidney issues that have been suggested over the years, there was no signal in these patients. Now, could there have been if these patients were followed for 10 years instead of 5 years? Yes, certainly, obviously. But the point I'm making is that I think patients probably in general have more trepidation about these medications than they need to. Are they side effect free? Absolutely not. And in fact, in that study I was just mentioning to you, there was an increased risk of enteric infections, probably because the gut is not being sterilized quite as effectively at lower doses of acid. But I think in general, patients should feel comfortable that taking these medicines, even if taking them chronically, is not going to get them into trouble.
Okay, Dr. Gershengorn.
Sorry about that, Dr. Weiss.
No problem.
Dr. Sheehan, I appreciate the talk. And I'm just curious, given your expertise and experience as an epidemiologist and a clinical trialist, I really like the connection you made between what you're hoping the future is here to what we do currently for breast cancer screening and colon cancer screening. But I think there's been a lot of discussion, right, about the potential downsides of over-screening and the false positives and what we do with those. And I'm just wondering if you think that your field is well positioned, given that this is a bit down the line, to, alongside the efficacy studies, actually study that? And do you think there's space for that, and is that important?
Thanks so much for the question, Dr. Gershengorn. And I think that that's a terrific question whenever you're thinking about increasing a screening program, is what are going to be the unattended harms here. And I think that this is no different in some ways, in that there will be, if we, especially if we use that proxy, the non-endoscopic screening as the front door to get in, we're going to get a lot of folks who are false positives. Now, at least as it's currently being thought of, if the screening program focuses on patients with chronic GERD and other risk factors, those patients theoretically would have been candidates for upper endoscopy anyway. So worst case scenario is the patient undergoes that sponge that I showed you. The sponge is positive. The patient goes to an endoscopy. The endoscopy does not demonstrate Barrett's esophagus. The sponge was a false positive. The patient has gone through an endoscopy they would not have otherwise gone through. That endoscopy adds cost. There's some risk associated with that endoscopy, well less than 1%, but not zero. And patients will have complications from those procedures. So absolutely, these are things that we need to discuss with our patients before we take them along that path. And that we as gastroenterologists, when we get referred a patient, say with a positive sponge, need to talk with folks to make sure they understand, hey, the next step in this workup is going to be upper endoscopy. Understand that there are some risks associated with that. Having said that, I do think that compared to some other screening measures, the potential downsides are perhaps not quite as great here, because unless we really, now if we widen this someday to be all patients, regardless of whether or not they have risk factors for this cancer, then I think the calculus changes a little bit. So we need to be very careful. And I think at a first pass, what we're doing now is we're studying these screening programs, is we're aiming in them at the folks that are at the highest risk. And I think that is well justified. I wonder if I could, Roy, if I could pick up something that's in the chat, which I think is a terrific question. I talked today from Dr. Lukakis. I talked today primarily about screening for esophageal adenocarcinoma. The comment is, what about screening for squamous cell cancer in smokers and drinkers? Thank you for asking that, because currently the societies don't have guidelines for screening this population. However, a chronic drinker and smoker is at the same risk for squamous cell cancer of the esophagus as a patient with chronic heartburn and other risk factors is for adenocarcinoma. And yet we have been slow to generate guidelines suggesting that these patients be screened. One thing that I want you all to take away with today is, if you have a patient that has an ENT cancer, that's a drinker and a smoker, that patient on upper endoscopy is at markedly increased risk for squamous cell dysplasia. It's a field effect. So checking them for squamous cell cancer of the esophagus is a good move endoscopically.
So I want to thank Dr. Shaheen for coming all the way from Chapel Hill through the internet to enlighten us today about this important topic. I want to thank Jamie Barkin and his family for the generosity in sponsoring today's lectureship. And I want to thank you all for participating. Please don't forget to use the link in the chat for CME and MOC credit. And I look forward to seeing everybody next week. Be safe and take good care of yourselves. Thank you. Nick, regards to everybody in Chapel Hill. Good to see you again.
Thanks, Roy. Good seeing you all.